to get out of that crisis. Other innovation is leadless pacemaker. You know, pacemakers are good for bradycardia, complete heart block, patient falls, comes to you with syncopes, elderly patient, degenerative AV nodal disease. So, and when we put standard technique is to put pacemaker in the infraclavicular region after cutting here, and then you put 2 leads in the right ventricular right ventricle. So many patients they get infected. They have infected pockets here and there. So then what you do then? So this is a very amazing pacemaker. It is called Micra. You see here, this is a bullet. This is a bullet-shaped device. This is called Micra. It is leadless pacemaker. No need for cut. Yes, it can go through this femoral vein. We have to take through femoral vein over a catheter, and you just deploy like a bullet. We have deployed this, and that is the delivering catheter which is moving. So this was a CABG, post-CABG patient with bilateral infected infraclavicular pockets, 75 years, diabetic. Risk of infection, recurrent infection. So we put this with, and it costs around 15 lakhs in our country. But you see the advantages. No cut, nothing, he goes home. And it has a battery life for around 8 years. This is not Micra, leadless pacemaker. Other important innovation is non-surgical aortic valve replacement. Severe aortic valve stenosis, the only treatment is aortic valve replacement, surgical aortic valve replacement. But now we have TAVR, transcatheter aortic valve replacement. So this was a patient with severe aortic stenosis, low ejection fraction. You can't operate on him. Elderly male, thin, frail, high risk of surgery. Then we do CT scan analysis to see the area of valve, calcium assessment, aortic size assessment. It just takes 1 day. And then we actually proceeded for transfemoral artery TAVR. It is called transcatheter aortic valve replacement. So we first balloon the valve. You see, we are ballooning that valve. You can see the calcium across that. See the calcium. Now we are ballooning this. We balloon it, and then you can just take your valve. This is a valve accurate from hospital science, very good valve, and you just deploy it. See the metal ground that opens. That is also non-surgically it is deployed. It is called TAVR, transcatheter aortic valve replacement. That is all. This is the final position. Now again you can, if the valve is not dilated, expanded, that you can again expand it. Simple technique, no ventilator, no cut through femoral artery, patient goes home next day or the other day. It is called TAVR, and we have done a lot of TAVRs at our center. Other technique is Micra clip, which I was discussing earlier. You see this patient, he was a post-angioplasty patient, elderly male, 25% ejection fraction, severe mitral regurgitation. You see the valve leakage here in echocardiogram. See the valve leakage. See the valve leakage in atria. IVC dilated. CHF. How can you operate this 25% ejection fraction patient? He will be high surgical risk. Mortality risk, our surgeon told 15%, 20%. Nobody will get it. Nobody will like to go on table for this surgical repair. So there is a technique called Micra clip. We can put a clip. See this animation. These are 2 leaflets, mitral leaflets, not coapting. You see the difference, the gap between the 2 leaflets, and we go through left atrial septal valve. Through left atrium septum, and this is a clip, and we can just mold it like this. We can root our clip, and it will hold the leaflet in between, and it will create 2 orifices. Mitral valve is single orifice, you can see. Now it will hold the 2 leaflets. So it will the leaflets will start coapting now. There is no coaptation here. This is a very beautiful procedure. See here. So it will create 2 orifices, but mitral regurgitation, it goes down. See, the 2 orifices now. But you have clipped that thing. This is called Micra clip. The MR gets reduced. And we did similar procedure at our hospital. We have done one procedure, it is too costly. It costs around 35 lakhs. 35 lakhs INR. In my country. It is quite costly, but it gives you hope actually. Cost will gradually comes down. Whenever there is a new innovation, costs are high, and it gradually comes down. We always put a TE Pro while doing mitral clip. It is just an echocardiographic procedure, 1 hour through femoral vein, no cut, nothing, no ventilator, and patient can go home in 2 days. That is how actually we did this procedure. Other important thing is ICD for those patients who are low ejection fraction patient. When we put ICD like defibrillator device for ventricular tachycardia, ventricular fibrillation. Now we have subcutaneous ICD. No need to cut basically that micro pacemaker, lead as pacemaker. We have subcutaneous ICD. No need to cut. You can put ICD through this simple skin into the sternum. You can place ICD over the sternum. It can give shock therapy and prevent sudden cardiac death in all those patients, HOC patients, younger patients, and those with low ejection fraction, low pumping power, prone for high risk of sudden cardiac death. This is called subcutaneous. So last but not the least, it is just not the interventional procedure, but innovations have been made in heart failure therapies also, and we know that we have a wonderful molecule now. It is called ARNI, valsartan sacubitril combination. We are using for every HFrEF patient. HFrEF means when your pumping power is less than 40%. But now trials have come up for HFpEF patient when your ejection fraction is normal. Even then, we have started using valsartan sacubitril. We don't have that much evidence, but it is non-inferior. So we should use in those patients who have got hypertension or HFpEF with congestive heart failure. Maybe it is a diastolic heart failure. Other important thing is a non-diabetic drug getting into the shelves of cardiology, like SGLT2 inhibitors, dapagliflozin. Many trials have been documented, DAPA-HF trial. So it is called SGLT2 inhibitor, the fifth pillar. This is called our fifth pillar of heart failure therapy. And it is very important that we should actually add this medicine to prescriptions of diabetic as well as non-diabetic patients who have got heart failure, even HFpEF patients. We have enough data, and the benefits are like the patient loses weight, and BP goes down. So many benefits, sugar goes down. So it is important that we use all these pillars of therapy in our all heart failure patients. Besides, the patient not responding, then go for CRTD device, EICD device, then isoleucine, another actually addition. Then we have LVADs, artificial hearts. Then we have heart transplantation. That is how we actually manage our heart failure therapy, and it is actually improved. Mortality has come down by 25% after addition of ARNIs and SGLT2. When it comes to preventive cardiology, which I begin with, so you have to actually offer your patient these important profiles. Like lipid profile is very important to look at LDL, HDL. Homocysteine is very important. Somehow, in some studies, homocysteine has been directly correlated with the incidence of more acute coronary thrombotic events. So whenever you have high homocysteine, you have to look at that. And then lipo is a very great important risk factor for early coronary artery disease. So when you have high lipo, now there are studies that acetamide, which is actually a cholesterol lowering drug, it helps in lowering down lipo levels. Acetamide. Earlier it was fenofibrates. Then HbA1c is very important. HSCRP actually, it is not a risk factor, it is a risk marker, HSCRP. So whenever any patient who has got uncontrolled diabetes, uncontrolled blood pressure, obese person, smoking, heavy smoker, alcoholic, and he's not on drugs, not walking, not active, and if he has got high HSCRP values, then this means the patient is more prone for acute coronary events. Better to start aspirin in these patients. Otherwise, as such, for primary prevention, there is no role of aspirin. Stress test is very important. CT calcium score is another addition to our preventive health checkups. So I would recommend that all those elderly patients or high-risk patients should get this CT calcium scoring done every 3 years or 5 years. So when you have high CT calcium score, it correlates with high incidence of obstructive CAD. So even if patient doesn't have any symptom of angina or breathlessness, and even treadmill test is normal, but if you have got high calcium score, then the possibility of severe obstructive CAD is very high. So offer them a conventional coronary angiogram when you have high CT calcium score. Nowadays we are doing CT calcium score in our preventive packages for high risk. That was all from my side, and this is the list of procedures done at Fortis Noida. I joined around 2.5 years back. I was earlier with Fortis Escorts Hospital, then I was at the AKMMC Hospital. So this is the list of procedures: 3,000 plasties, angioplasties, chip case. Chip is complex, high risk indicated angioplasty when you are not able to do bypass surgeries. And maximum procedure imaging guidance. So I would recommend all higher authorities is that you should actually take IVO on board. This will lower down the complication rate, improve outcomes, and it will actually help your patient. If the cost actually is around, it adds around 50,000 to whole coronary procedure, but it will make a difference. 8 divers, 300 pacemakers, ICDs, 8 dividers. So many things actually we are doing. We do around 100 angioplasties in a month. That is how actually we are contributing to our neighborhood population for cardiac deliveries. And now recently we got an AI powered cath. This is AI powered cath. So what it does, you just have to take 2 coronary shots and it can give you whole of the picture. Biplane AI powered angiogram. So like you do angiography of a patient who has got 50% block, and other patient who has got 50% block, and if you do 1 shot, it will tell us it is like that device, the whole of the ECG will come, and you can actually it will be transferred to an app, and your cardiologist or physician can see that ECG. So that is how innovations are now making a difference to our comfort, or patients' comfort, or outcomes. So everybody gets benefited from these. Thanks a lot for it.